Picture this. You walk into a doctor's office for a routine checkup. You walk out with a surgery date, no real conversation, no real options, just a recommendation that felt more like an order. If that has happened to you or someone you love, you are not alone. And today we need to talk about it. Because after 70, the body changes in ways that can make even common surgeries carry far heavier risks than most people realize. And the truth is, not every procedure that gets recommended is actually the best path forward. I am not here to tell you to avoid doctors or ignore medical advice. I am here to give you the knowledge to have a smarter conversation with your doctor, so that when a surgical recommendation comes, you know exactly what questions to ask. Stay with me to the end. One of these 6 procedures might be the most important thing you hear this year. Understanding the relationship between aging and surgical risk is not something most people think about until they are sitting in that exam room. Today we are going to change that. Before we get into these, I want to be clear. The information in this video is for educational purposes only and is not intended as medical advice. Always consult your physician or a qualified healthcare professional before making any decisions about your health or treatment options. Okay, now let's get into it. Surgery number 1, spinal fusion for degenerative disc disease. Back pain is one of the most common complaints among people over 70, and when imaging scans show worn-down discs or narrowed spaces between vertebrae, spinal fusion surgery often comes up as a solution. Here is what you need to understand first. Degenerative disc disease sounds alarming, but for most people over 70, some degree of spinal degeneration is completely normal. It is part of the aging process, the same way wrinkles appear on skin. The question is not whether the changes are visible on a scan. The question is whether those changes are actually causing your symptoms, and whether surgery is the most effective way to address them. Spinal fusion joins 2 or more vertebrae together permanently. The operation typically involves general anesthesia, significant blood loss, and a recovery period that can stretch from 3 months to a year. For a 45-year-old with excellent bone density and strong cardiovascular health, that recovery window is challenging but manageable. For someone in their late 70s who may have thinning bones, reduced heart or lung capacity, or early cognitive changes, the same recovery looks very different. There is also a phenomenon called adjacent segment disease. After fusion locks certain vertebrae in place, the vertebrae directly above and below the fused area take on more stress. This can lead to new degeneration and sometimes a second surgery, something few patients are told about during the initial recommendation. Here is a question worth asking your surgeon directly. What will my daily function look like 12 months after surgery compared to where I am today? Not just pain level, function. Can I walk my neighborhood? Can I dress myself? Get in and out of a car? If those answers are vague, push harder. For many seniors with moderate, stable back pain, structured physical therapy focusing on core stability, targeted stretching, and postural correction has produced meaningful improvements without a single incision. Weight management, anti-inflammatory nutrition, and aquatic exercise are tools that deserve a full, honest trial before surgery enters the conversation. Surgery for spinal instability causing nerve compression, loss of bladder control, or rapidly worsening weakness is a different situation entirely. That may genuinely require intervention. But surgery to address pain alone, especially when daily function is still reasonably intact, deserves careful thought. Surgery number 2, carotid artery. Surgery for a symptomatic narrowing. The carotid arteries run along each side of your neck and carry blood to your brain. If one of them shows narrowing on a scan, it can feel alarming. Stroke is devastating, so when a surgeon says that clearing the blockage will protect you, the instinct is to say yes immediately. But let's slow down and look at the actual evidence. Carotid endarterectomy, the procedure to remove plaque from the artery, carries its own real risk of stroke, heart attack, and nerve injury. In patients who have already had stroke symptoms or mini-strokes called TIAs, the calculus often favors surgery because the risk of another event is high and imminent. But in people with no symptoms, someone who simply had a routine scan, and learned about a narrowing, the picture is far more nuanced. Studies have shown that in asymptomatic patients, the difference in stroke risk between surgery and careful medical management is smaller than most people expect, and the procedural risk itself increases with age. The urgency behind a recommendation for carotid surgery can feel overwhelming, but urgency and necessity are not the same thing. Ask this: have I had any symptoms? Sudden vision changes, face drooping, arm weakness, slurred speech, even briefly? If the answer is no, ask your doctor what the actual numerical difference in stroke risk is between surgery and optimized medication. Ask for the numbers, not a general statement, specific percentages based on your age and degree of narrowing. Many seniors in this situation are well served by aggressive blood pressure management, statin therapy, low-dose antiplatelet medication, and regular monitoring. The artery does not disappear from the picture, it gets watched carefully, and if symptoms develop, the conversation shifts accordingly. A second opinion from a vascular neurologist, not just a surgeon, is extremely valuable here. Surgeons are trained to operate. Neurologists who specialize in stroke prevention are trained to evaluate the full picture. If this is speaking to something you or a family member has experienced, drop a comment below. Your story matters, and it may help someone else watching today. And if you have not subscribed yet, now is a great time. We cover topics like this every week. Surgery number 3, total knee replacement for moderate arthritis. Knee replacement surgery is one of the most performed orthopedic procedures in the country, and when it is done at the right time, for the right patient, it genuinely restores quality of life. The problem comes when it is recommended before conservative options have been fully explored, or before the patient truly understands what recovery demands. Here is something many people are not told up front. The rehabilitation after knee replacement is intense. It begins within 24 hours of surgery and continues for months. You will need to push through significant pain and swelling to regain range of motion. If you stop early, if rehabilitation is incomplete, the results suffer dramatically. You may end up with a joint that feels stiff, unstable, or only marginally better than before. For a senior dealing with other conditions, heart disease, diabetes, obesity, or early dementia, both the surgical risk and the rehabilitation demand increase substantially. There is also an often overlooked consideration: implant longevity. Modern knee replacements typically last 15 to 20 years. If you are 72 and receive a replacement, there is a reasonable probability the implant will loosen or wear out before the end of your life, requiring a revision surgery, which is far more complex and carries significantly higher complication rates than the first procedure. Before saying yes to a total replacement, consider this. Have you completed a full, committed course of supervised physical therapy specifically targeting quadriceps strength? The quad muscles, the large muscles on the front of the thigh, act as natural shock absorbers for the knee. Strengthening them reduces joint loading significantly. Many patients who complete a serious strengthening program find that surgery can be delayed by years or avoided entirely. Other options worth exploring: corticosteroid or hyaluronic acid injections for symptom management, bracing, and anti-inflammatory dietary approaches. Surgery becomes far more reasonable when pain is severe and constant, function is significantly limited despite conservative care, and the patient is in good enough overall health to tolerate both the procedure and the rehabilitation that follows. Timing matters enormously. Choosing the right moment, not just the first available moment, can make the difference between a successful outcome and a difficult one. Surgery number 4, coronary stenting for stable artery disease. When a cardiologist shows you an image of your coronary arteries and points to a narrowing, fear takes over. The instinct is immediate: fix it, clean it out, get that stent in. But here is something that the medical community has debated extensively. In patients with stable coronary artery disease, meaning the arteries are narrowed but there is no active heart attack and symptoms are controlled with medication, stenting does not consistently reduce the risk of future heart attacks compared to optimized medical therapy alone. This is not a fringe opinion. Major clinical trials have examined exactly this question and found that for many stable patients, aggressive medication management statins, blood pressure control, aspirin or other antiplatelet agents, and supervised cardiac exercise programs, achieves comparable outcomes to stenting without the procedural risk. And there are procedural risks worth knowing about. Stent placement requires threading a catheter through an artery, typically the wrist or groin, up to the heart. Complications can include bleeding at the access site, artery damage, kidney stress from the contrast dye used during imaging, abnormal heart rhythms, and in rare cases, stroke. After a stent is placed, and strong antiplatelet medication is required for months to prevent clotting inside the stent, and that medication carries its own bleeding risks. After 70, the kidneys are often less resilient to contrast dye. The arteries are less elastic. The body's tolerance for procedural stress is reduced. The conversation to have with your cardiologist is this: is my condition stable or unstable right now? What is the specific evidence that stenting will reduce my risk of a heart attack compared to optimizing my medications? If the answer is not clear and evidence-based, ask for time. Ask for a second opinion. Ask to see a cardiologist who specializes in medical management, not just intervention. In an acute heart attack, a stent can save your life. In that moment, there is no question. But stable disease is a different conversation, and you are allowed to take time to have it. Surgery number 5, surgical treatment. For mild prostate enlargement. For men over 70, urinary changes related to an enlarged prostate are extraordinarily common. Slower urine flow, more frequent trips to the bathroom at night, the occasional sense of urgency. These symptoms range from mildly inconvenient to genuinely disruptive. When they are at the more disruptive end, surgery gets recommended, and it is worth knowing exactly what that recommendation means before agreeing. Prostate procedures, whether transurethral resection, laser therapy, or newer minimally invasive techniques, are not without consequence. They require anesthesia, and anesthesia after 70 carries an elevated risk of postoperative cognitive effects. Temporary confusion, memory gaps, or disorientation are more common in older adults following any procedure requiring sedation, even brief ones. Beyond cognition, there are functional risks specific to prostate surgery. Urinary incontinence, sometimes for weeks or months after the procedure, and retrograde ejaculation, where semen travels backward into the bladder during orgasm rather than forward. For many men, these outcomes affect self-confidence and quality of life more than the original urinary symptoms did. There is also an important distinction between an enlarged prostate that is inconvenient and one that is medically dangerous. Dangerous enlargement causes complete urinary retention, the inability to urinate at all, repeated urinary tract infections, kidney damage from backed-up pressure, or bladder stones. In those situations, intervention is clearly necessary. But for men whose main complaint is waking up once or twice at night, or who have some urgency during the day, a structured conservative approach deserves a real trial first. Reducing fluid intake in the 2 to 3 hours before bed, eliminating caffeine in the afternoon and evening, bladder training exercises, alpha blocker medications to relax the prostate and ease urine flow. These approaches help a meaningful number of men enough that surgery becomes unnecessary. Ask your urologist to score the severity of your symptoms using a validated scale. The International Prostate Symptom Score is commonly used. Ask where your score falls. Ask specifically whether the degree of obstruction is medically dangerous or primarily uncomfortable. Then make your decision with that clarity in hand. Surgery number 6, aggressive surgery for slow-growing cancers. No word changes a conversation faster than cancer. The moment it is spoken, fear floods in. The impulse is to act immediately, to remove it, to fight it, to do everything possible. But after 70, the relationship between cancer, treatment, and quality of life becomes more nuanced than at any earlier point in life. And for certain slow-growing cancers that are common in older adults, the most evidence-based recommendation is sometimes not surgery at all. Low-grade prostate cancer is the clearest example. Many prostate tumors found through screening in men over 70 grow so slowly that they would never cause symptoms or threaten life within a realistic time frame. Yet major surgery, a prostatectomy, carries risks of urinary incontinence, erectile dysfunction, and anesthesia complications that can permanently affect daily life and independence. Active surveillance, a structured program of regular PSA testing, repeat biopsies and imaging, is an accepted guideline-supported alternative for low-risk prostate tumors. It is not passive neglect. It is deliberate monitoring with clear criteria for when to escalate treatment if the tumor changes behavior. Similar considerations apply to small thyroid nodules, indolent early-stage lung nodules, and some early kidney masses. In younger patients with decades ahead, the calculus leans toward aggressive removal. In seniors in their late 70s and 80s, the math shifts. The question is not just whether the tumor could eventually cause harm, it is whether treatment will cause harm first and whether the benefit is large enough and likely enough to justify that risk. Post-operative delirium is a particular concern after major cancer surgery in older adults. It is more common than most patients are told. For some seniors, cognitive function does not return fully to its pre-surgery baseline. That is a life-altering consequence of a procedure that may not have been necessary. The question to ask your oncologist is direct. If I choose active surveillance instead of immediate surgery, what is the realistic probability that this tumor becomes life-threatening within the next 5 to 10 years? And what are the chances the surgery itself affects my cognition, continence, or independence? Getting honest answers to both questions gives you the information you need to decide, not based on fear, but based on facts. Living past 70 is not a vulnerability, it is an achievement. And with that achievement comes the right and the responsibility to be a full participant in every medical decision that concerns you. Surgery is a powerful tool. It has restored function, saved lives, and given people back years of meaningful living. But it carries risks that accumulate with age. The brain, the heart, the kidneys, the bones, they recover differently at 80 than they did at 50. That is not pessimism, it is physiology. And understanding it makes you a better advocate for yourself. Before any surgical recommendation, ask 3 questions. First, is this condition urgent or is it stable? Second, what are my non-surgical options and have they been fully tried? Third, how will this procedure affect my independence, my cognition, and my quality of life? Not just in the short term, but over the next several years? You are not being difficult when you ask those questions. You are being wise. Which of these 6 procedures was most surprising to you? Have you or someone you love faced a surgical recommendation that felt rushed? Tell me in the comments. Your experience might be exactly what another viewer needs to hear today. Thank you for being here. Please share this video with someone who might need it, and I will see you in the next one.